Welcome to the deep dive. Today, we're tackling a really fascinating area, congenital vascular malformations. Now, these aren't your typical tumors. They're lesions present right from birth, basically errors in how blood vessels get formed, like developmental miswiring, maybe.
Yeah, that's a good way to put it. And what's interesting right off the bat is that for years, just talking about these conditions was a real headache.
Oh, how so?
Well, everyone used different terms. Imagine like trying to solve a puzzle when everyone calls the pieces different names. It was confusing.
Exactly, like a medical Tower of Babel.
Okay.
But thankfully, the International Society for the Study of Vascular Anomalies, ISSVA,
All right.
they stepped in.
Right.
They created a clear biological classification system back in '96, updated in 2018. Huge step forward. Finally, everyone's speaking the same language, more or less.
Precisely. And this system, it basically puts everything into two main buckets: vascular tumors and vascular malformations.
Yeah.
Vascular tumors are about cells growing too much actual growths, things like infantile hemangiomas, Kaposiform hemangioendothelioma, tufted angioma, those sorts of things.
Right.
So while those are important, our surgical focus today, it really hones in on the malformations, the developmental errors in the vessels themselves.
Okay, so not things that grow aggressively like a typical tumor. We're looking at issues that are there from the start.
Yeah.
And these malformations, they get broken down further based on the plumbing involved, right?
That's right. The subclassification, it depends on two key things. What kind of vessel is affected? Capillary, lymphatic, venous, arterial, or maybe a mix. And then how fast the blood flows through it. So you've got slow flow and fast flow malformations.
Okay, let's get a handle on the slow flow side first. What are some examples there?
Your slow flow lesions are things like capillary malformations, often called CMs.
CMs, right.
Lymphatic malformations, or LMs. And venous malformations, VMs. Think lower pressure systems.
Got it. CM, LM, VM, slow flow, and the fast flow ones. That sounds like a whole different ballgame.
It is, yeah. The main ones you'll hear about are Arteriovenous Fistulas, AVFs, and Arteriovenous Malformations, AVMs.
Yeah, that's right.
Imagine like a high-speed connection bypassing the usual traffic flow. And then, just to add another layer, you can get combined malformations, where you see a mix of different vessel types. Conditions like Klippel-Trenaunay Syndrome or CLOVES Syndrome, they fall into that category.
Wow. Okay. So it sounds like pinpointing exactly what's going on is just absolutely crucial before you even think about treatment.
It's paramount.
Yeah.
Accurate diagnosis is the foundation. Choosing the right path.
And that's where imaging comes in.
Exactly. We rely heavily on tools like ultrasound, CT scans, MRI, really mapping out the extent of these things, not just the structure, but crucially the blood flow dynamics. That helps tell them apart from, non-vascular growths too.
And for the faster flowing ones, I guess you need to actually see that rapid flow in action.
You do. Angiography is often used for AVMs. Think of it like creating a roadmap of the blood vessels. It highlights that central tangle, the nidus in the arteries feeding in, how the blood drains away. And for lymphatic issues, lymphoscintigraphy can show lymphedema. More detailed stuff like digital subtraction, lymphangiography, MR lymphangiography, they really light up the lymphatic system's anatomy, any blockages.
So we've got this detailed classification, we've got the imaging. Now, today our focus is really diving into the surgical side of managing these, but it's important to remember surgery isn't the only tool.
Well,
right?
Oh, absolutely correct. There are other important treatments. Conservative things like compression garments for swelling.
Right.
Medications like sirolimus can be very effective for certain types. And endovascular treatments like sclerotherapy, injecting stuff to close off abnormal vessels. But yeah, for this deep dive, we're zeroing in on the surgical approaches.
Okay, let's start with those slow flow ones then. Beginning with capillary malformations, the CMs.
Okay.
What do we need to know about surgically addressing these?
Right. CMs, as we said, usually flat, pink to red skin lesions at birth, birthmarks, basically. What's important surgically is that sometimes they're linked to overgrowth underneath fat, even bone, or they can be part of those combined syndromes.
And the typical surgical approach for just an isolated CM, is there one?
Well, for CMs on their own, surgery isn't usually the first choice, no. Cosmetic things like flash lamp, pulse dye laser, or ND by AG laser therapy, that's the standard.
Okay.
But say a patient is having surgery for a bigger underlying venous or lymphatic malformation, the surgeon might remove part of the CM then as part of that larger debulking.
Aye.
And in cases with both a CM and that underlying tissue overgrowth, a staged zonal surgical excision might be used, tackling different areas at different times.
That makes sense. Address the bigger issues first. Now moving on to lymphatic malformations, LMs. These sound like they can be quite varied.
They certainly can be. A key insight for LMs is that the size and nature of the cyst that largely dictates whether we lean towards, say, minimally invasive sclerotherapy or if we need surgical removal.
How do you classify them?
We classify by cyst size, macrocystic if they're bigger than a centimeter, microcystic if smaller, or mixed. That, plus location and extent, is crucial for treatment decisions.
And these aren't just static, are they? I remember reading they have some unique behaviors.
That's right. LMs, they're unique. They can get infected themselves, cellulitis, even bacteremia.
Wow.
And interestingly, their size can fluctuate with other illnesses. Swell up when you have a cold, maybe. Bleeding into the lesion can happen too, from trauma or an abnormal vein connection. And on the skin, they can look like reddish purple to almost black, fluid-filled bumps, vesicles.
And location seems really important, especially head and neck LMs.
Absolutely. Cervicofacial LMs, head and neck, are quite common. They can cause real problems with breathing, swallowing, and then congenital issues with the central lymphatic system. That can lead to serious stuff like chylothorax or chylocystitis, lymphatic fluid leaking into the chest or abdomen.
Which causes?
Respiratory distress, malnutrition, low protein, low lymphocytes can even erode bone.
So given all that, what are the surgical considerations for LMs?
Generally, macrocystic LMs often respond better to sclerotherapy. You drain the cysts, inject something to make them collapse.
Okay.
Microcystic ones, though, they often need surgical removal. Resection is also an option if sclerotherapy doesn't work well. And for really large LMs, even if they're mostly macrocystic, surgery might be preferred. Sclero alone might not shrink them enough.
What about asymptomatic ones?
Sometimes just monitored, but if there's deformity, function problems, leakage, recurrent infections, treatment's usually needed. Ideally, if surgery is the way, we like to wait till the child's at least 6 months old, unless the airway is immediately threatened.
Okay, let's talk technique. Removing a subcutaneous LM, what's involved?
For a subcutaneous LM that's caused significant tissue expansion, often a lenticular excision, like removing a lens-shaped piece, we try to include as much involved skin as possible, skin with creases, dimples, those vesicles, to try and prevent future leaks. Then, the remaining skin and subcutaneous tissue are carefully separated from the LM, creating flaps.
Does it look different from fat?
Yeah, it can sometimes look similar, but it has a distinct, almost spongy texture. Helps during dissection. If there's no normal subcutaneous tissue and the LM goes right into the dermis, we can do a deeper dissection to ensure a good blood supply to the skin above.
And I imagine working around nerves gets tricky.
It certainly can. An intraoperative nerve stimulator is very helpful there. Identify and avoid injury, especially if the LM is close to or surrounding vital structures.
Right.
And remember, LMs aren't cancer, so the goal isn't always removing every single cell. Preserving important structures is the priority.
Makes sense.
We might also need stage surgeries sometimes for residual LM or cosmetic refinement, but repeat surgeries are tougher because of scar tissue. So we aim to be thorough first time, though even then there's a chance it could re-expand over time.
And post-op care, what's typical?
Closed suction drains are usually placed. They manage the often significant lymphatic fluid leakage.
How long do they stay in?
Sometimes weeks, even months. It's important to prepare patients and families for that. If there's a lot of excess skin after removing the LM, we might excise that too for a better cosmetic result. Complex cases might need specialized flaps for coverage and reconstruction.
What about LMs elsewhere, like the abdomen or pelvis?
Yeah, treating symptomatic abdominal and pelvic LMs can be quite complex. Size, organ involvement.
Right.
Sclerotherapy is often first line there. Surgery is usually for cases that don't respond well. Laparoscopic excision, minimally invasive, has shown to be effective sometimes. We always try to avoid removing major organs if possible.
But sometimes unavoidable.
Sometimes. Splenectomy, removing the spleen, might be needed if it's very enlarged or problematic from LM involvement. If an LM affects the GI tract, causing pain or obstruction, bowel resection might be needed.
I also saw mention of LMs affecting genitals and managing fluid leakage.
Yes, penile LMs. If the swelling isn't controlled by compression, surgical excision of the whole affected subcutaneous layer can help minimize recurrence. Managing leaks, like chylous pleural effusions from chest LMs, is challenging.
How do you approach that?
Initially, non-operative stuff. Medications like octreotide, special low-fat diet, IV nutrition, maybe sirolimus to reduce lymphatic flow. Tying off or blocking the thoracic duct, the main lymph vessel, can be considered, but very cautiously, especially with widespread lymphatic issues, could worsen obstruction.
Are there other options?
Rarely surgical shunts or drainage catheters. For persistent leaks from blockages in main channels, a lymphatic venous bypass might be an option, connecting the thoracic duct to a nearby vein, like the external jugular.
And post-op, even in these complex cases, drains are still common.
Absolutely. Crucial. Left until drainage is minimal to prevent fluid collections. With abdominal LMs, there's also a risk of postoperative ileus, temporary gut paralysis. Might need an NG tube. And those little skin vesicles that can pop up in the scar, we can treat them locally with sclero or CO2 laser, or remove them, though they can come back. That's why we try to bring healthy dermis over the resection initially.
This is all incredibly detailed. Let's switch to venous malformations, VMs. These seem to have their own unique issues.
They do. VMs can be there at birth, but might not cause symptoms for a while. A key thing is they tend to get bigger when standing or straining things that increase pressure.
Right.
The slow flow inside can lead to small blood clots, phlebothrombosis, causes pain, swelling. If a VM involves bone or joints, it can even lead to fractures or joint bleeds. Muscle VMs. Pain, swelling, worse with activity or dependency, can be linked to skeletal issues too: overgrowth, undergrowth, fractures, deformities.
So how are these managed initially?
Conservative management helps. Compression garments for clotting episodes. For patients with signs of increased clotting activity in blood tests like high D-dimer, fibrinogen daily low-dose aspirin or low molecular weight heparin might reduce symptoms.
And when is surgery considered?
Generally for lesions causing significant symptoms, cosmetic issues, or functional impairment. Crucially, you must check blood clotting studies before surgery due to that localized clotting risk within the VM.
Okay. And what kind of VMs are best for surgery?
Well-localized ones in a defined area are most straightforward to remove completely. For larger ones causing uncontrolled pain, limb length difference, bleeding, severe cosmetic issues, or movement limits, debulking, reducing the size, might be the main surgical goal.
And sclerotherapy?
Can be used for VMs that can't be entirely removed, or sometimes before surgery to help shrink it and reduce blood loss.
I also noticed mention of GI tract VMs, including something called blue rubber bleb syndrome. Sounds specific.
Yes, VMs can pop up anywhere from mouth to anus. Blue rubber bleb syndrome, BRBNS, is where multiple VMs, often skin and GI tract.
What do they look like?
Skin lesions are small, bluish, raised bumps. In the GI tract, they can cause intussusception bowel telescoping, causing intermittent belly pain, mild blood loss and stool, often managed with iron. But severe bleeding or obstruction might need surgery. Interestingly, sirolimus has shown a promise for reducing pain and improving quality of life in BRBNS.
So for surgically removing VMs, say in arms or legs, are there special techniques?
Absolutely. A tourniquet is very helpful to minimize blood loss. These things have delicate abnormal vessels. They spread into tissue, so bleeding risk is high during dissection.
How so?
Cutting a VM is like cutting a sponge, bleeds easily. Standard ways to stop bleeding: cautery, clamps, sutures can be tricky. So specialized hemostatic devices like bipolar sealers, ultrasonic scalpels are invaluable. We also try to include affected skin in the incision. VMs can act like tissue expanders, so once removed, there's often excess skin you can excise. We carefully raise flaps, thin flaps if the VM involves the dermis, preserving blood supply. Careful protection of nerves, tendons, joints. Always close suction drains in the flaps. Very large resections might need local or distant flaps or skin grafts.
What about surgically tackling BRBNS lesions inside the GI tract? Sounds tricky.
For BRBNS in the gut, the goal is removing individual lesions if possible. Techniques like wedge resection, band ligation, polypectomy, suture ligation, segmental resection. Removing individual lesions is preferred over taking out huge sections of bowel.
How do you find them all?
Intraoperative endoscopy is crucial. Camera scopes from mouth to anus during surgery to find lesions you can't see or feel from outside. Then mark them with sutures or dye to guide removal. If there are many packed VMs in large segments, more extensive surgery like colectomy, anorectal mucosectomy, maybe a colonal pull-through might be needed.
And I recall something about anorectal VMs and the inferior mesenteric vein, a potential complication.
Yes, really important point. Anorectal VMs can sometimes link up with an abnormally dilated inferior mesenteric vein. This can siphon blood flow away from the portal vein system, potentially portomesenteric thrombosis clots and portal hypertension. So patients with rectal VMs should be screened for this. If found, that vein can be surgically tied off proximally to prevent clots.
What about VMs in solid organs, like the spleen?
Symptomatic ones might need surgical removal, either partial resection or, if it's extensive, complete organ removal. The example given was a child with a splenic VM causing pain who needed a splenectomy.
And VMs in the genital scrotum, labia. Specific considerations there.
Yes, bulky scrotal VMs. Sclera might be an option, but repeated sessions mean radiation exposure to testes, so surgical resection is often preferred. Labial VMs, sclero can be done, but essential to shield the ovaries. Surgical reduction usually best after puberty, though massive ones might need earlier attention. Clitoral VMs. Avoid sclerotherapy risk to nerves, vessels. Resection with careful preservation is recommended.
And finally, after VM surgery, follow-up and potential complications.
Important for patients to know. If it's not completely removed, it can reconnect, enlarge over time. May need more procedures, more sclerotherapy. Post-op complications can include hematoma, some skin necrosis, persistent swelling. Brains stay until output is minimal.
Let's shift gears now to the high-flow malformations, specifically arteriovenous malformations, AVMs. These sound like they bring a very different set of challenges with that rapid flow.
They certainly do. AVMs have abnormal direct connections between feeding arteries and draining veins, bypassing the normal capillary network entirely. Might start as just a faint pink mark, but can expand over time, especially with hormonal changes like pregnancy, puberty, or after an injury.
And that expansion causes problems.
Big problems. Skin ischemia, lack of blood flow, a steal phenomenon, like a river diverted, normal tissues downstream don't get enough blood.
Which leads to
Pain, ulcers, functional impairment, nerve compression, even destruction of bone and soft tissue. Bleeding, too. And in severe cases, large AVMs can strain the heart, cause high-output cardiac failure. That needs urgent attention. So even asymptomatic ones, we generally prefer to treat before they progress.
So what's the typical surgical strategy for AVMs?
Often a combined approach, embolization plus surgical excision. Pre-op embolization, done by an interventional radiologist, blocks off the central nidus and main feeding arteries.
Right.
Then surgery follows, usually within 2 to 3 days. That short interval is important. They can sometimes re-expand rapidly in between.
What about just blocking the feeding arteries?
Generally avoided as the main treatment, unless you're absolutely sure you got the whole AVM out. Just tying off proximal feeders can backfire. The AVM can recruit other arteries, recur, and become even harder to treat. Embolization can also be used palliatively for extensive AVMs where complete removal isn't possible, helps reduce flow symptoms.
And the surgical removal itself, what's the main objective?
Complete excision, with clear margins of normal tissue around it. Need to get the whole nidus and any involved skin.
Yeah.
Focal, localized AVMs. Much better long-term control after complete excision. Diffuse ones. Higher recurrence risk. Any remaining abnormal vessels can reconnect.
How do you know if you got it all during surgery?
Intraoperative Doppler ultrasound helps visualize flow. Observing bleeding patterns at the edges helps guide resection. Interestingly, frozen sections, quick biopsies during surgery haven't proven very helpful for determining if the margins are clear for AVMs.
And reconstructing the area after removal sounds like it could be extensive.
Immediate reconstruction is often needed. Skin grafts, local flaps, regional flaps, even microvascular free flaps taking tissue with its own blood supply from elsewhere.
What if the defect is really large?
Vacuum-assisted closure devices, other tissue transfer techniques might be used, and in very severe extremity, AVMs with loss of function, irreversible damage. Unfortunately, amputation might be the only option for pain relief and improving well-being.
What about AVMs in the chest or abdomen? Similar management.
Thoracic and abdominal AVMs often need a combined approach to sclero, open surgery, tailored to location and extent. Chest AVMs, often intrapulmonary in the lung tissue, can be linked to hereditary hemorrhagic telangiectasia, managed with partial lung resection or embolization.
GI tract AVMs.
Rare, but often present with bleeding. Embolization might buy time, but recurrent or severe bleeding usually needs surgical resection. Splenic AVMs, uncommon, treated with splenectomy. Pancreatic AVMs can cause portal hypertension, GI bleeds. Embo for straightforward ones, but permanent control often needs bigger surgery, like a pancreaticoduodenectomy.
Wow.
Complex liver AVMs might need hepatectomy, even liver transplant rarely. Congenital arterioportal fistulae, abnormal artery to portal vein connections can cause ascites, pain, GI bleed, malabsorption. May need hepatectomy or ligation if embo fails.
It sounds like they can really pop up anywhere. Urinary tract, genitals?
Yep, urinary tract AVMs,
Yep.
hematuria, hypertension, flank pain. Localized ones might be resectable. Genital AVMs, often combination embo and resection. Buttock AVMs involving gluteal muscles. Resection if embo fails.
Given the complexity and recurrence risk, what about post-op care?
Long-term follow-up is absolutely crucial. Significant recurrence risk, rates vary a lot. Patients need monitoring for early signs. Redness, tiny visible vessels, telangiectasias, swelling, pulsation, bleeding, or the Suen sign, that rapid soft tissue rebound on pressure. Regular exams, sometimes imaging for early detection.
We've covered a lot on individual types. Now, what about when they occur together in combined syndromes like Klippel-Trenaunay and CLOVES? Sounds even more complex.
Combined vascular malformations, like in KTS, Parks-Weber syndrome, PWS, CLOVES, they present a really wide spectrum of challenges, often affect multiple systems.
Tell us about KTS.
Klippel-Trenaunay is a slow-flow combo, typically capillary, lymphatic, and venous malformations, often with significant overgrowth of soft tissues, bones, usually in limbs. Capillary malformations can be extensive. Patients might get lymphatic vesicles on the skin, weeping, bleeding. Lymphedema is common. And interestingly, the deep veins in the affected limb might be missing or underdeveloped. Often abnormal superficial veins too, including that primitive lateral embryonic vein of Serval.
And those venous issues cause problems.
Yeah, risk of cellulitis, pain, swelling, bleeding, thrombophlebitis, clots, even pulmonary emboli. So essential to get good vein imaging before any treatment.
And Parks-Weber syndrome, that involves faster flow.
Correct.
Yeah.
PWS is characterized by a fast-flow capillary AVM or fistula, usually in arms or legs. Because of that high flow, the heart can get overworked, leading to congestive heart failure. Might need embolization to reduce flow.
And Klippel syndrome sounds even broader.
Absolutely. CLOVES includes congenital lipomatous overgrowth fatty masses, plus vascular malformations, epidermal nevi, seizures, scoliosis, other skeletal spinal issues.
Where are the fatty masses typically?
Often on the trunk, flank, present at birth. Can extend to the chest, abdomen, even spinal canal. Cause deformity, functional problems, extremity issues too. Large hands, macrodactyly big digits, wide feet with a sandal gap between toes. And like KTS, anomalous veins present a risk of pulmonary embolism.
Given these complex combinations, what's the non-operative management look like?
Often focuses on symptom control, preventing complications. Compression therapy is a mainstay. Pain, swelling, heaviness from venous insufficiency, lymphedema. Usually start around age 4 or 5. Pneumatic compression devices can help too, though expensive. Abnormal veins. Historically resected, now endovenous laser ablation is more common.
And when surgery is needed for these combined types, goals and techniques.
Surgery mainly focuses on debulking, reducing the size of the soft tissue overgrowth. Contouring procedures to improve appearance, function. Often staged, tackling worst areas first.
Common areas for debulking.
Trunk, genitalia, perineum, buttock, lower extremity. Might also be done for frequent soft tissue infections due to the overgrowth. Asymptomatic chest mediastinal lesions, usually managed conservatively. Because of the clot risk, might use anticoagulation pre-post-op, maybe a temporary IVC filter. Pre-op imaging is crucial. Need to know if overgrowth is outside or within the muscle fascia.
Why is that distinction important?
Debulking intrafascial overgrowth carries higher risk of injuring major nerves, vessels, could cause weakness, immobility. For limb length differences from overgrowth, epiphysiodesis, slowing growth in the longer limb might be needed.
And the actual debulking techniques.
Tailored to the patient. Focus on most problematic areas first. Remove as much bulk weight as possible. Tourniquets help. Intraoperative cell-saver machines minimize transfusion needs. Often a lenticular excision incorporating skin lesions if possible. Incise skin, carefully lift flaps of skin fat. If malformation involves the dermis, dissect cautiously to preserve blood supply limit undermining. Remove abnormal tissue between muscle fascia and skin. Drains, then reapproximate flaps. The overgrowth itself often acts like a tissue expander, so there's often excess skin to remove.
What about severe cases?
Very severe cases, relentless symptoms, destroyed joints. Amputation might be considered as a palliative measure. Improve quality of life.
And the post-op period for these complex cases? Sounds involved.
It can be. Patients need preparation for possible delayed healing, prolonged drain use, sometimes weeks. Altered circulation, poor lymph drainage means flaps can struggle. Healing can take weeks or months. Drains removed when output is very low. Not uncommon to see lymphatic vesicles pop up in around the scar later, often treatable with laser.
This has been an incredibly thorough overview. To really tie it together, could you briefly walk us through a general approach or algorithm? How surgeons decide treatment based on the type?
Absolutely. So the general approach starts, of course, with accurate diagnosis history, exam, imaging, ultrasound, MRI, CT, maybe biopsy.
Right.
For capillary malformations, if mainly cosmetic, observation or laser. For lymphatic malformations, depends on size, symptoms. Small, asymptomatic, often watch. Larger, symptomatic. If mainly macrocystic, sclerotherapy, maybe with sirolimus, is often first line.
And microcystic.
If predominantly microcystic, surgical resection or sclerotherapy with bleomycin, again, potentially with sirolimus. Mixed or extensive LMs might need a combo. Sclero, surgical debulking, sirolimus.
Okay. Venous malformations.
Small asymptomatic VMs, observe. Symptomatic, well-defined. Surgical removal may be combined with sclero, more extensive or symptomatic. Sclerotherapy, potentially with surgical debulking.
Arteriovenous malformations.
AVMs, the primary approach is often embolization to reduce flow, frequently followed by surgical resection.
And finally, combined malformations.
Depends on the most significant parts. Substantial soft tissue overgrowth. Surgical debulking, possibly with sirolimus. Significant arteriovenous component. Embolization, maybe with or without surgical resection, and sirolimus.
That's an incredibly helpful summary. Really emphasizes how tailored the approach has to be.
It truly does. The key takeaway: no one-size-fits-all. This algorithm is a framework, but the plan is always individualized.
This deep dive into surgical management of congenital vascular malformations has been incredibly insightful. It's just so clear how complex and varied these conditions are,
Yeah.
and how much progress has been made, in understanding and treating them classification, the range of strategies.
Yeah, and what's fascinating to consider is that while surgery is often critical, it's almost always part of a broader multidisciplinary effort, isn't it?
Absolutely.
You've got surgeons, interventional radiologists, stomatologists, hematologists, many others, all working together, providing the best care, the long-term follow-up these patients need.
It really highlights the importance of that accurate diagnosis, developing a plan truly tailored to the individual. And, it makes you wonder, given these start so early in development in the room, what future breakthroughs in understanding embryogenesis might lead to. Preventative strategies, maybe, or even less invasive treatments down the line. For those of you listening who want to explore this more, definitely look into the ISSVA classification, the reference literature. It's a constantly evolving, really fascinating field. Thank you for joining us on this deep dive.